Hello everyone and welcome to today's webinar. This webinar is live and interactive and you are encouraged to participate by posting questions to the presenter, which can be typed into the chat box located at the bottom left-hand side of your screen. If you experience any problems with losing internet connection or dropouts and freezing, please ensure that you are connected using a hardwired internet connection rather than Wi-Fi. If this becomes a problem for you throughout the webinar, please contact our support team or let us know via the chat box. If you have any audio issues during the webinar, please dial the teleconference number listed in the chat box below, or alternatively, you can contact our support line on 1800 733 416, and this number is also listed in that chat box. I'd now like to pass you over to Louise to begin today's webinar.
Thanks, Michelle. Hi, my name's Louise Brown. I work in the translation and education area of Jean Hales, and together with the Continence Foundation of Australia, we're really excited to present our second webinar for health professionals tonight. I'd like to start by acknowledging the traditional custodians of the land we're presenting and the lands we're reaching tonight, and pay respect to elders past, present and future. For those of you who don't know, Jean Hales for Women's Health is a national not-for-profit organisation dedicated to improving the knowledge of women's health throughout various stages of their lives and to provide a trusted world-class health service for women. We combine research, clinical care and practical education for women and health professionals. We've had about 370 or more registration for tonight's webinar, which is fantastic. And at the moment, I think we're close to 100 or so people online. So just a reminder that as advertised, tonight's webinar is focusing on urinary incontinence in women. So we're not covering fecal incontinence and we're not looking at continence issues in men at all. We're going to use the chat box, as Michelle said, throughout the night, and hopefully we can get to as many questions as possible. We've also received questions when you registered, so we've got those in mind as well, and we'll try and work through them once we have a bit of time. Just to test out your chat box, if you go down to that left-hand side, you can type in where you are tonight, and that'd be nice. We can see where everybody's dialed in from. Hopefully you might have had a chance to look at the pre-reading that you received when you registered for the webinar, and from the tab down on the bottom right-hand side, there's documents available. So if you would like to access any of those documents, they're available down on that right-hand side. So you can see there's a few resources that will probably be spoken about tonight. So the way this the session will work is that we will have each speaker do their introduction, and then we'll work through 3 different case studies. At the end of each case study, we'll have time for those questions, so you can please type them in the chat box. I'll firstly like to introduce tonight's speakers. We've got a fantastic expert panel. I'm not going to read their bios. They are in that documents folder down the bottom, but we've got Associate Professor Anna Rosamillia, who's a urogynecologist. We've got Jemana Ryan, a urology and continence nurse consultant, and we've got Jean Hales, pelvic floor physiotherapist, Janetta Webb. So welcome to our panelists, and thanks for joining us. So we'll start by hearing the key points from each of them, and then we'll work on the case studies. So firstly, we'd like to start off with Anna. So welcome to Anna.
Thank you, Louise. So I'd welcome to everybody. This brief overview really, and it is pretty difficult to cover this topic in 5 minutes, but there's a brief overview of how we'd approach a female patient who presents with continence issues. So if we, just a few sort of comments to make really to start with. What is normal bladder function? So first of all, we really can't accept that any sort of incontinence is normal. And so that's a premise that we work by. It's not uncommon, but it's certainly not normal, and people shouldn't put up with that. That normal voiding is 7 to 8 times during waking hours and 1 or less at night. And that urinary incontinence is quite common. It occurs more commonly in women than men. It does occur, however, in nulliparous women even, and it certainly increases with age. And there are a number of risk factors for urinary incontinence that we would all, probably we'd know most of these if we thought about it, but a very common risk factor is age. and then pregnancy, and then vaginal delivery, obviously. Anything that raises the intra-abdominal pressure, like chronic cough or constipation, heavy lifting, obesity, any pelvic surgery which potentially might have an effect on the vascular and the neurological supply to the continence mechanism, the urethra, the urethral sphincter, the pelvic floor musculature. And then certainly a whole range of medical conditions can contribute, and other issues like mobility, etc. And there is certainly a genetic factor that can't be dismissed. So just briefly, if a patient comes in with this sort of complaint, then it's very important to go through some of the pertinent questions in history taking that are going to include the daytime frequency, nocturia, the type of incontinence. It's most important. So is it something that occurs with increased abdominal pressure, or is it very much a urge-related problem? So is it classically key in the door, or is it only at the gym? Is it small amounts? Is it large amounts? How bothersome is it? How much in the way of sanitary protection is the patient using? How long she had the problem, and the chronology of that. Does it date from a particular time? And then there are other urinary and other pelvic floor symptoms that are extremely important. So is there any voiding problem? Is there a poor stream or hesitancy? Is there any hematuria? Are there recurrent urinary tract infections? And then bowel dysfunction questions, either constipation or difficulty with bowel emptying. And of course, sexual function questions and questions about prolapse, about a vaginal bulge. So all of these questions are quite well summarised in the Australian Pelvic Floor Questionnaire, which is in your documents. Obviously, physical examinations are then important, and there are some screening assessments. So a screening for prolapse, screening for pelvic mass, screening for neurological intactness and mobility, and screening for a cough stress test. And Janetta's going to go into more detail about how we assess the pelvic floor, and I'm going to leave that to her expertise. The types of investigations that we would do when we're assessing someone with incontinence who walks through the door, the most important investigation I find is a bladder diary. So I will often ask people to come along, having had a urine culture, having brought in their bladder diary, because then I can make most of the diagnosis then and there, rather than waiting for them to come back with a bladder diary. Bladder diary just requires the patient to measure their intake and their output over a 24-hour period, the voided volumes and the time. And that gives us a lot of information about their bladder function, and points us to the direction as to what might be contributing to their bladder control issue. Then there are some more involved investigations which are relevant in some cases. So particularly in an elderly patient, or particularly in someone who's got neurological symptoms, it's important to make sure that they are voiding properly. And so, because sometimes incontinence can be the presentation of overflow. And so it's important, and that's easily done by a ultrasound, post-void residual assessment. Sometimes we have to do some more involved investigations, such as a urodynamics investigation, which is a test that we do. It's our basic bladder function test. It tells us how well the bladder empties, how much it holds, why is there leakage, what the cause of the leakage is, and there are certain times when when that would be indicated, and it's usually when conservative therapies aren't working, or when there's uncertainty about diagnosis. We sometimes have to look into more involved assessments, such as cystoscopy, when we're trying to see if there's a cause for hematuria, for instance, when we're trying to rule out malignancy or post some sort of complication of surgery potentially. And certainly imaging is very useful, either for ruling out contributing factors like renal stones or a pelvic mass. Those investigations are generally, certainly the imaging can be readily performed, and the post-void residual and diary and urine culture is fairly easy to obtain as well. The red flags that I would see that would indicate referral to a specialist would be if there was uncertainty as to the diagnosis, particularly in the case of severe incontinence, when there's a lack of response to adequate trial of conservative therapies. And we're going to spend some time talking, you'll hear from Jemana and Janetta about conservative therapies, when there's hematuria, when there's severe pelvic organ prolapse, and that means when there's pelvic organ prolapse that is beyond the vaginal introitus, when there's a sign of voiding dysfunction, if there's a neurological condition, because then really the critical thing, if there's a neurological condition, is that this incontinence may be a sign of upper tract compromise. So that's not just that's a serious health issue, obviously. And when there's a history of pelvic surgery, that may indicate that that there's more involved assessment that's required. So if we look briefly at overall management of a patient with incontinence, and Jemana and Janetta are going to go into more detail, particularly about the conservative treatments, it requires education. It requires our trying to correct aggravating factors, which may involve the use of topical estrogen. It might involve advice about fluid management, about avoidance of caffeine. And we need to sort of look at basically how their pelvic floor muscle function is, whether we can improve upon that by supervised training or by adjunctive therapy. Again, Janetta will talk about this. Bladder retraining, re-education, and that's basically the mainstay of behavioural modification to try and address the problem of urgency and urge incontinence. If those techniques aren't sufficient, then sometimes in the situation of a patient with overactive bladder, we sometimes have to use bladder relaxant medications, and there's a number of these, and we can talk about this if there's time. If refractory to that, then there are some techniques such as intravesical Botox, which has been very effective for those refractory cases, and even neuromodulation. If the problem is very much a stress incontinence problem that hasn't responded to pelvic floor muscle training, reduction of BMI, and all the other types of techniques that we could use, then which include in some cases continence devices, then surgery might be indicated, and also there may be concomitant prolapse, which also may benefit from surgery if it is in the severe category. So mid-urethral sling is the current most commonly performed surgery for stress urinary incontinence, and happy to discuss that later. And I just wanted to make the point again that urinary incontinence does not usually occur in isolation, and we often have to address other associated dysfunctions such as prolapse and such as bowel and sexual dysfunction. So briefly, overactive bladder, the types of treatments we have, ditropan and oxytrol are the two medications that are available on PBS. Tolterodine, solifenacin, darafenacin, and these are the other anticholinergics that are available on a private script in Australia. There are others overseas, but they haven't arrived here yet. And then the new kid on the block is mirabegron. Mirabegron is not an anticholinergic. It's a completely different, it works on an adrenergic pathway and therefore doesn't have the dry mouth side effects. Unfortunately, it doesn't have PBS status either. Then in terms, just some brief information about the efficacy of Botox. So Botox has been useful in refractory OAB. So in this large study that was published in the New England Journal, they did a study looking at women who had 5 urge incontinence episodes per day as baseline, and they found that they compared Botox to solifenacin, which in other words is Vesicare, it's the trade name, and they found a reduction in both. However, the dry rate was higher in Botox, with all quality of life questionnaires being very much better. And the downside to Botox is that there's a temporary need for a catheterization in a small number, and in this study it was 5%, we find that it's probably a little bit less than that. The other possible treatments for OAB, peripheral tibial nerve stimulation, happy to discuss that. That's just, we've just started to get some experience with this, and implantable sacral neuromodulation, which is, again, for the more refractory cases prior to consideration of really major urological surgery. Synthetic slings. So synthetic slings, we said before, was the most common procedure now for stress urinary incontinence. We have one of the most studied surgeries in gynecological literature is the retropubic midurethral sling, the TVT. 2 years ago, we had 17-year data for that, and overall, there's a cure rate of about 85%. And it can be performed as day case or overnight procedure, so it has an advantage over a fascial sling, which is what it replaces, which involves more wound incision and morbidity. And with every surgery, of course, we also always have to counsel about the downside. So the downside being that it doesn't always fix bladder overactivity, and in a small number it might worsen it. And there may be voiding dysfunction, which might, in a small number of cases, need adjustment of the sling, and other issues like mesh erosion, which is thankfully uncommon for the slings. And there's some evolution of those types of slings with the retro pubic sling being this one. And this is sort of the original version. It's now smaller. It's 3 millimeters, and it doesn't have these scary trocars. And this one is a obturator sling. And then we have also a mini sling, and we're doing some work with this. So thought just briefly to give you a bit of an overview of some of what we do. And this is just a reminder, really, that it's very important to, you know, even in situations where a surgery is indicated, that there's a big role for conservative treatment, pelvic floor muscle training, and bladder training. Thanks. Thanks, Louise.
That's a great overview, I think. Now we'll move on to Janetta and the physiotherapist approach to managing this problem. Thanks, Janetta.
Thanks, Louise, and welcome everyone. Great to have such a great enrolment. So I'd like to continue on to talk about the specifics of the physiotherapy approach. There is level 1 evidence for pelvic floor muscle training as being the first line of management in the treatment of female urinary incontinence. I won't go into this list of challenges to the pelvic floor. Anna has mentioned them all, apart from the incidence of low back pain. So there is a strong correlation between the incidence of low back pain and pelvic floor dysfunction. So I would encourage anyone who is treating or caring for women who are experiencing low back or pelvic joint pain to also ask the question about bladder control. So most women have heard of their pelvic floor, but these are the things that we most commonly hear. I've heard about my pelvic floor, and I know I'm supposed to exercise my muscles, but I don't know how to do it. So we know that brief verbal instruction of pelvic floor exercises is helpful in about 50% of women, but that also means that there are many women who perhaps aren't correctly contracting their pelvic floor. Either it's not moving at all, or they may actually be bearing down. Often women will say they've tried pelvic floor muscle training, but it hasn't changed their symptoms. And in this situation, that is usually due, if they're correctly contracting their muscles, it's usually due to insufficient intensity. So pelvic floor muscle training is really intensive over a period of a few months at least. And I think also often women may have said the above two things and don't really feel hopeful that they can make a change. So it's our role as a continence nurse, physiotherapist or urogynecologist, and of course your role in whatever is your profession, to encourage women that pelvic floor muscle training can be effective. Certainly make sure that with the women in all of the groups mentioned before, so back here that Anna mentioned, that you're checking, how is your bladder control? Do you have any issues? And if you're wanting a good place to start for pelvic floor muscle training, the Continence Foundation resources, looking on the website, there are an amazing number of downloadable and printable websites in many different languages that can be a great place to start. So if a patient's come along for physiotherapy assessment, of course that will start with history taking, some of the points that Anna already discussed, but specifically education about the anatomy and the function of the pelvic floor muscles, and once you attain good function of your pelvic floor, how that is going to change your continence. So it's really important for women to understand, okay, I know I need to do these exercises, but what is it actually going to do and how is it working? We will always assess the pelvic floor muscles. It may be an external visual perineal assessment if it's inappropriate for any reason to perform a per vaginum assessment, but of course the best way to palpate the pelvic floor muscles is internally, vaginally. And it's really important to focus during physiotherapy sessions on the acquisition of the correct technique of pelvic floor contraction, because without that it's not going to be effective. It's also important that women are able to relax their pelvic floor muscles. So just as many women who have pelvic floor muscles that are not functioning and causing problems with continence, there can also be issues with pelvic floor muscles that are overactive or hypertonic and also causing other issues. So it's really important, as well as clients being able to engage their pelvic floor and contract it, that they're able to relax it. I'm interested in the symmetry of pelvic floor function, so it is frequently asymmetrical. I'm interested also in the coordination or co-contraction of other muscular groups. So it's very important that women are not breath holding when or doing any sort of forceful manoeuvres when they're contracting their pelvic floor. And there are many facilitation techniques that can be used to assist with the correct acquisition of technique. We look at tone of the pelvic floor muscles, the what's called the levator hiatus, so the size of the gap between the two sides of the pelvic floor muscles, both at rest and on contraction. If there's been any trauma during childbirth to the attachments of the pelvic floor muscles, which is called an avulsion, or of course any pain on palpation, which could be a signal that there is some overactivity. I'm interested in the reflexive function of the pelvic floor with coughing, because women who have lost that, of course, very frequently experience stress incontinence and leakage with coughing. And then we're also looking at strength, endurance, and the coordination of muscle function. And I think, as you can see, there are so many things that are important with pelvic floor muscle function that I'm not so sure that when a woman's trying to acquire this technique that she can actually do them everywhere. So often women say, I try to do them everywhere, in the car, at the traffic lights. That's okay once you've got good pelvic floor control, but to start off with, you usually need a lot more focus. So you need to be focused on just doing pelvic floor exercises. After all of this assessment, then the woman receives an individualised training program, and this will usually start off with a few sets of exercises each day. So it's quite intensive initially. It's important for pelvic floor muscle function to be reassessed and for the program to progress. So a woman who initially has very weak pelvic floor, hopefully she's going to improve her pelvic floor strength and function, and then her program needs to be progressed so that she gets to the stage of being able to exercise her muscles and control them in the situations in which she experiences leakage. For example, to be able to functionally brace her pelvic floor muscles when she coughs. And it's important for us to listen to the patient's goals. So, one patient may wish that she only had to wear 1 continence pad a day instead of 4. Another patient may want to be able to run and be dry. So it's very, very important. I've talked about the intensive training and the length of muscle training and the importance of assisting patient adherence to the program. So giving the patient feedback, making sure that she understands her program and setting realistic goals, including helping to focus on those goals during periods of plateau. So certainly the most important thing is pelvic floor muscle training. And these other adjunctive therapies can assist with pelvic floor muscle training, but they never replace it. So surface EMG biofeedback is an excellent tool that patients love, but again, it's always with a pelvic floor training program, and it's just giving the feedback to the patient as to how she's going and improving during a treatment session. Electrical muscle stimulation, which is usually provided, if appropriate, with an internal vaginal electrode, but can also be used with external stimulators, can be very helpful for women who are unable to contract their pelvic floor or have very weak pelvic floor muscles to attain a reliable pelvic floor contraction and to assist with training. And vaginal weights, although there's not strong evidence for their use, there's something that a lot of women, particularly women in the postpartum phase, do like to use as training. And other things that we discuss. So firstly, general fitness. And please note that as a type of fitness to specifically strengthening the pelvic floor muscles, if a woman is performing Pilates, she needs to ensure that actually she is able to contract her pelvic floor muscles correctly before she attends a Pilates session. So just going to a Pilates class, particularly a large Pilates class, may not necessarily attain a pelvic floor contraction and certainly won't be at the intensity that a woman needs if she is symptomatic. As Anna mentioned, the importance of avoiding repetitive heavy lifting, and we may teach bowel evacuation dynamics, which I won't go into the details of now. So the CFA, pelvic floor muscle training for women, is a great place to start. Metropolitan and rural continence clinics all have multidisciplinary teams, including physio, but I'm aware certainly that for some of you there may not be one close to your home, and also public hospital, urogynecology or urology clinics. And don't forget, as GPs, that you can, via the Enhanced Primary Care Program, refer your patients to physio for a Medicare rebate. And down the bottom is just a website in which you can see where local physios are to your area for referral. Thanks, Louise.
We've just got a poll coming up, so if you'd like to participate in that, we'll have a couple of those during the evening. So thank you for that lovely summary of physio management of continence issues. Now we'll move on to Jemana, who's going to tell us her approach from a continence nurse perspective. Thanks, Jemana.
Thanks, Louise. Welcome to everybody to our webinar on continence. I'm hoping to contribute in a good way in regards to what nurses are able to contribute to helping people in their continence journey. Now, as you know, when patients usually come to us in regards to having problems with continence, it's usually that they're presented to their local GPs with problems in regard to having stress incontinence when they're having a pap smear done, or the GPs notice that they may have a little bit of prolapse. It's a great way to start a conversation about what can be done about this issue. A lot of women are not always sure about whether it is normal that they do leak after they've had kids, or that they do leak when they do exercise, and having that open discussion about that. Yes, Yes, that they can get help about this problem is a good reason to talk about it. Women are usually really anxious about coming to have an assessment done or to talk to somebody about their issue. And I always think it's really important to find out what the woman's actual problem is and what she considers to be the main problem with what's going on with her bladder before the next test is done. One of the things that both Anna and Janetta have talked about is completing a bladder diary. When women present, sometimes they have done their bladder diaries, other times that they haven't. And I think the importance of doing a bladder diary is so important for us to find out what's actually going on with their bladder. We can actually find out a lot about what type of fluid intake that they've been having, how often they're drinking, are they sipping slowly throughout the day, or are they having large glasses very, very frequently. We look to see what their fluid output is. How often are they going to the toilet? Is it coming with, do they go to the toilet with urgency, or are they going to the toilet just as a normal need to go? We look at if any patterns are established. I always think it's very interesting to see how people go overnight. How often are they getting up overnight? What's waking them up? Is it that they are needing to go to the toilet, or is it that they are not sleeping very well and go to the toilet just in case? We get them to fill out a few questionnaires, as Anna mentioned previously, and they are in the documents that you're able to access, and that gives a lot of information about when bladder problems occur for women. I always perform urinalysis on women who present. We look to see if there is any signs of infection, as well as looking for other things such as blood or glucose. We often pick up people who are actually diabetic at this phase, and sometimes that's a discussion that we need to send them back to the GP about. We also talk about weight at this point as well, and talking about how controlling weight or reducing weight can actually improve their bladder function. We often talk about their urine loss, and I get women to describe to me when it actually occurs. Does it occur with an urge, or does it occur with sort of activity? And sometimes those symptoms can be quite mixed up, and it's sometimes not. I'm not quite sure which one it is. And it's through the use of looking back through the bladder diary that I can actually decipher whether it is an urgency type scenario, or whether it more or less could be stress. I spend a lot of time talking to patients about their bowel regimes or their bowel problems. For some women, they don't have many problems with their bowels, but for some women, they feel they're incompletely emptying their bowels, or they find it very difficult to have a bowel motion. Other people can talk about bloating and like fluctuating between constipation and a loose bowel. And I find that's really important part of the picture to find out for women what they are experiencing. I also look at skin issues that can be associated with the urine leakage they're experiencing. For some women, you know, they only leak a very small amount of urine, so the skin problem is not an issue. But for a lot of women, if they are leaking a lot of urine, skin issues can be a big problem. For some women, they're using not the right type of pad. They're still using sanitary pads. Pads designed especially for urine loss work much better than the ones used for menstruation. We also have a look at different types of barrier creams that women can use. There are some barrier creams that women can use that can actually clog up pads, so therefore they're not working as well as they used to. I look to see what is what clothing women are wearing when they come into the clinic. You know, are they having difficulty getting those pants down when they need to go to the toilet? Are they able to change independently? A lot of women will sometimes wear 3 pads stacked on top of one another, and just having a discussion about a better way to use continence aids, or maybe moving up to a different size pad. When it comes to the discussion about skin as well, I also talk to women about what they use to clean those areas, and sometimes women will try and use soaps on those sensitive areas, whereas we should try not to use soaps on those areas, and it can actually inflame a lot of skin problems that do occur around the vulva. As I've said, we talk to women about when that loss is occurring. If it's occurring during activity, during sleeping, during jogging, for instance. We talk to them about how often. We liaise back with that bladder diary to see whether it all goes together. You know, what they're describing as a problem, is it being reflected in the bladder diary? We talk to women about how tricky it is to get into their house. So many women talk about lining up outside public toilets, and there's 4 people in a row, and they're getting more and more urgent to go to the toilet and getting panicky about, are they going to make it? Women often talk about leakage that occurs as they've got their key in the door. I'll often talk to women about different strategies to try and avoid getting into that situation, like, for instance, before getting in the car, going to the toilet, then not waiting until you get home. I also talk to women about how they're going to the toilet. Do they have problems emptying their bladder? When they go to public toilets, do they feel that the person next to them is emptying and having a really good stream, and they're only just trickling away? And sometimes, as Anna was saying, we will do a flow rate on these women and see if that correlates to what they're saying in regards to their emptying. We will perform an ultrasound, have a look to see how much is left. Also talking to women about if they have any anxiety about going to public toilets, and feeling comfortable about completely relaxing that pelvic floor and allowing themselves to empty their bladders. You'll find that some women do have a lot of trouble. Some women even don't want to sit on the toilet and have great difficulty in actually relaxing to sit on the toilet to do a wee. I also talk to women about self-directed fluid restriction, and also the other extreme is where they have way too much fluid. Sometimes women will come into me and say that they've got urgency problems, but when we look at how much fluid they're drinking nearly 3 or 4 litres a day. I know I would be having urgency problems if I was drinking that much, and I would be going very frequently. So talking about what a reasonable intake is, what we want to measure as being a reasonable output. So here's just a couple of pictures of that I got to try and describe what actually happens to women as the key in the door, or that long wait to get into a public cubicle. So some of the key messages that I wanted to talk about is, I want to listen to what women want to improve, what they do know about their pelvic floor. Have they done it in the past? And a lot of women will say that they have done pelvic floor exercises and that it hasn't fixed. And just informing women that it's a long process, that if the muscle's really weak, it does take a long time, and that they need support in order to get that pelvic floor program off and running and really working on it diligently. As Janetta said, you can't just do pelvic floor exercises at every moment, like at every red light, as they often say on different programs. It's better to have a planned attack of how you're going to do those pelvic floor exercises and do them in a controlled way, and making sure that you're doing a lovely strong contraction. I think the biggest thing is that women need the support to know that it takes time, and that a couple of weeks isn't long enough to see a change, that it does take a couple of months to really get a change to occur in pelvic floor strength. And the thing is that once that pelvic floor muscle gets much stronger, it can actually help in regards to helping women brace before they do a cough, before they do a sneeze, or when they get that urgency feeling, to help them brace so they're able to hang on and ride out that urgency feeling until that urgency does go away. Talking about a change in behaviour. A lot of women will often go to the toilet on the first signal from their bladder. It's sometimes good, especially when you're in a safe place, to put off going to the toilet when you're in I say a safe place, meaning you're at home, the toilet's there, it's available. You know, you need to go to the toilet, put it off, go and unpack the dishwasher, go and do something else around the house before you go back to going to the toilet. Try and put it off for 5-10 minutes, and that amount of time slowly starts to extend. At first, you may think that 5 or 10 minutes isn't long enough, but really, very slowly, those changes will start to occur in that bladder's behaviour, and we'll be able to hang on for longer and longer. So making sure that we take time to tell women that it does take time for that strength to return and for that change in behaviour in regards to getting that bladder to change. So again, we look to see what the woman wants to improve, what's achievable, and offer support so that we can hopefully improve women's pelvic floor function. I like to provide lots of information about the problem that the woman's got. If it is about urgency, I love to give women lots of information. The CFA have magazines that come out every season. They've had a great series on bladder overactivity. There was an article by Jo Lee, as well as an article just recently about overactive bladder, the different ways to help women with pelvic floor function. Oh, sorry, about overactive bladder. So women can see that they're not alone, that there's other people who have got those same issues. I try and keep different articles so that I can give women these resources when they come in. The CFA has some wonderful resources about how to do pelvic floor exercises. They also have some great resources for nurses to use to learn how to do pelvic floor exercises. They have some in-service programs that are fantastic. Nurses also have Nurses for Continence, as well as Urology Nurses Association, who run great education programs for nurses to help them deal with continence issues, to help them deal with learning how to assess a pelvic floor and doing pelvic floor exercises. I also put down the IUGA education sheets. I use them a lot to give to patients so that they have access to that information. I would never hesitate in regards to referring to physio. I always feel that I start the process, but sometimes women will need ongoing management and keeping up, and referring to physio is very important into making sure there's a long-term improvement in regard to women's health. I also look at continence funding. So if some people are on the pension, for instance, I look to see what different funds are available for them. So find out what their eligibility is and help them and direct them into the right path onto what they may need help with. Okay, thank you, Louise.
Okay, thanks, Jemana. All the panelists have provided, fabulous information. We've gone over time, but that's great. I think the information that's being provided is really useful. There was just a question that came up. Define UGSA. Now I'm thinking that's the Urogynecology Society of America, but you will find the link to their resources in the continence resources sheet. So if you go back down to that documents folder, there's a whole lot of resources that'll probably be quite useful. So I suggest you have a look there. Now we're going to move on to the case studies, and I'm going to ask each presenter to, thanks Michelle, the arrow. I don't actually know how to use that arrow, but there it is. We're going to look at our first case study, which is Emma, a 36-year-old G2P1, forceps delivery baby, 3,600 grams. So she's presenting, and I think some of these case studies are your typical things that you're seeing probably in your practice. As a nurse, you would hear about them when a woman comes in, and I think all of you working in the various fields that we've got online tonight will find this is a common one. So she's got urinary incontinence, happened after her baby was born. She's leaking at the gym, wants to go back to exercise. Her best friend's had this problem fixed with day surgery. So I think it's probably, we might just start with Anna because she's come in wanting surgery. We'll let Anna respond to this, and then of course conservative management is where she may end up first. But I'll let you start off, Anna.
Thanks, Louise. So first of all, I think apart from the obvious assessment and physical examination, we basically have a discussion about the fact that this is quite common, that approximately 20% or more of women will have stress urinary incontinence 12 months after their first delivery, if it's a vaginal delivery, and something like 16% if it's a caesarean delivery. So certainly vaginal delivery does increase her risk, but possibly in some series forceps does too. But by no means is caesarean section totally protective. So we need to work out why it's worsening. Is it because she's gone back to the gym, and that's the common time when it worsens, when there's more physical activity and more exertion. But the key factor is that it doesn't look like she's had any conservative treatment, and she could well find that with conservative treatment that she may cure or significantly improve her bladder control to the extent where it's not something that she would want to have surgery for. So I would always refer her to treat aggravating factors, like if she's put on weight, and certainly pelvic floor muscle training with Janetta. I'll hand over to Janetta. I would say that if she did, after an appropriate trial of conservative therapy, still was very adamant to have surgery, I would say that ideally that we would perform surgery after she's completed her family, because there is the potential for subsequent pregnancy and subsequent delivery to make the bladder control deteriorate again. So ideally, however, if the patient is distressed enough, surgery can be performed, but it should have to be counselled fairly carefully about that. And the other offer that we could have for her would be continence devices, such as pessaries, etc. I would not recommend a caesarean delivery for her subsequent pregnancy mode of delivery, and some people would ask for that potentially, because it won't make any difference to the outcome. Thanks, Louise.
I might hand over to you, Janetta, for your approach. For your approach with this woman.
Thanks, Louise. Yes, I'd be really keen to see Emma. The first thing I'd like to say is thanks very much, David, for pointing out that the CFA Physio's website is .com.au, not, as I had put it, .org.au. So thanks very much for highlighting that. So I'd like to educate Emma on the effects of pregnancy and childbirth on her pelvic floor. As mentioned before, an assessment and teaching of correct pelvic floor technique. And I'm going to be emphasising with her initially the strength and coordination, the speed of engagement of her pelvic floor muscles, and also her endurance. So particularly if she's having issues at gym, I don't want her to be leaking at gym. But there are some things that will need to be changed. So I'd be really keen to look at modifications of her exercise program. And you can see these sorts of modifications if you look at the Pelvic Floor First program. So there are downloadable, or you can order in hard copy from the continence.org.au website, the resource list, the Pelvic Floor First pamphlets, and also there is a Pelvic Floor First app, which is free and downloadable also. So I'd want to significantly modify her exercise program and check that what she's doing as, in inverted commas, core exercises, remembering that actually the pelvic floor is the lower part of the core, are appropriate. And I'm also wanting to check that she doesn't have any pelvic floor overactivity, because many women have been overtraining their, again, core, in inverted commas, at gym. The core is not just the abdominals, it's the diaphragm, the pelvic floor, the back muscles, and the abdominal muscles, some in particular. I'm wanting to also progress her pelvic floor training to a functional level. So Emma needs to be able to engage her pelvic floor muscles when she coughs, when she sneezes, when she lifts. You know, I may want to, depending on how soon she's wanting to conceive, to actually assist her to then be able to engage her pelvic floor with, you know, higher impact or more stressful exercises at gym. But generally in the initial training phases, we're trying to keep it low impact, and that before any exercise that increases her intra-abdominal pressure, that she's engaging her pelvic floor. And it's very important that she's monitored during pregnancy to ensure that her symptoms are improving. If she does conceive while she's still having physiotherapy, and I would probably want to see her during that time anyway. Someone sent in a question prior to the webinar tonight about what happens if pelvic floor exercises flare up coccyx pain. So my suggestion there would be to tell the woman to stop doing her pelvic floor exercises, and she needs a check to see you know, what's going on with her coccyx, what's causing the pain, how is she contracting her pelvic floor, and then a re-education back to pain-free pelvic floor exercises. There was also a question that's come in tonight. Thanks everyone for when should you begin pelvic floor exercises and what's the cutoff point. Never too young, never too old, really. But certainly I'd like to see teenage women, you know, when, you know, at menarche starting to learn about their pelvic floor muscles and to be able to exercise their pelvic floor muscles and to engage them correctly. But again, the importance of not overtraining the core. So we certainly don't want women to be walking around with their pelvic floor drawn up all throughout the day. But certainly, yes, never too late to exercise your pelvic floor as long as you have the cognitive ability, you know, to understand instructions and to, you know, contract your pelvic floor muscles voluntarily. Thanks, Louise.
About any research around pelvic floor training devices or apps in terms of their success, or I'm just wondering if any of you know of any research that's actually looked, because there's an app for everything these days pretty much. I actually don't know any of these apps, but Janetta, I don't know whether you know of any research that's been done in this area and how successful it is.
Yeah, thanks, Louise. Yes, look, there is quite a bit of research looking at electrical stimulation and biofeedback, but in a nutshell, those adjunctive therapies, as I called them before, are in addition to pelvic floor muscle training. So the most important thing is that if anything is going to be done, it's pelvic floor muscle training first, but then you can also add biofeedback or electrical stimulation as appropriate. There was particular mention of the PeriCoach, which is a biofeedback device. It's in the early stages of use, and in fact there's a trial underway in Melbourne looking at the use of the PeriCoach, but so far no results because the trial has only started fairly recently. In terms of the apps, I don't know of any research because again these apps are recently developed, but certainly the apps for pelvic floor first in pregnancy and pelvic floor first generally that you can download and see information about them on continence.org.au I think are really useful, and women report anecdotally that they're really helpful. Thanks, Louise.
We've also got another webinar in the Jean Hales webinar library that it's actually, we've got a pelvic floor first ambassador who's actually talking about exercise, pelvic floor safe exercise. So that's probably another one, particularly for those of you who are in that field of exercise training, personal training, things like that. Jemana, have you got anything that you would like to add to the management of Emma from your point of view as a continence nurse?
Look, the only other thing that I would add in regards to this lady is her daughter's 3 years old, and I'd really look at how often she's lifting her up and making sure that she is, once she knows how to engage her pelvic floor, that she is bracing before she lifts her up. Any mum who's got a 3-year-old is quite busy with doing different bits and pieces around helping her child, and sometimes those things that we do with our children can make our pelvic floor worse. So that's the that's what I would add in regards to that. Also, in regards to what types of pads she's using, she's currently using sanitary pads. You can use incontinence pads, and they're really small in comparison to the sanitary pads and have much higher absorbency. So that's the only other thing that I would add to what Janetta and Anna have already said. Thanks, Louise.
Okay, thank you. We've also had a couple of questions come in around the management of continence issues in younger women who may not have given birth. I mean, and there are other risk factors too, but I would imagine that the management would be the same in terms of conservative management, whether you've had a baby or not. Would you agree with that, say, Janetta?
Louise, could you just repeat that? I was just reading Sarah's questions that she sent through. Sorry, Louise.
Oh, look, no, there was just a couple of questions, one that came in before the webinar and one that's come in saying, what are the options for young women who've got urine leakage, who haven't given birth? And I was just saying, well, it's not only childbirth that's causing these problems, as we know, and that the management, whether you've had a child or not, is probably going to be similar in terms of pelvic floor training.
Yeah, sorry, thank you. Look, I think so, but there could be, other causes. I think it's very important to have screening first. So, as Anna's already talked about, things that, a GP, initially just checking that it's not a urinary tract infection, other screening questions that Anna has suggested a GP should ask. And also to be mindful of the fact that not just that overactive pelvic floor muscles occur in young women, they can occur in any woman, but a woman who has pelvic floor overactivity, for example, through overtraining at the gym, overtraining of her core or for many other reasons, that's not the only cause of overactive pelvic floor muscles, could also be experiencing urinary leakage. So when pelvic floor muscles are overactive or hypertonic, they are usually quite weak because, they're not able to relax fully to then contract strongly. So even that can be a cause. So I think, yes, very important for, for adequate assessment and then, the specifics of bladder training, of course, bladder diary, and looking at her pelvic floor function. Thanks, Louise.
Okay. Thank you. I think we've covered that one quite well. I'm sure there are some other questions there and I'll try and come back to them if we can, but I'm aware of the time. So I'd like to move on to Diana. She's 63. She's had 3 children, and you can see the other issues there. She's had urinary tract infections. She's got increasing frequency, intermittent constipation. So I'll let you read those details. And this time I might start off with Jemana.
Okay, well, in regard to this lady, I'd be making sure that she feels that we get a bladder diary, that she fills one out so that we can find out exactly how often she's drinking, how often she's emptying, what types of fluids that she is drinking. I'd also be having a look at how well she empties her bladder. We do a flow rate, do an ultrasound and residual to see how much is left. We'd look to see how she empties her bladder. With her urinary tract infections, I'd want to have a look and see what types of infections she has had, what types of organisms keep reoccurring. I'd want to make sure that that Anna's reviewing her to making sure that she's had testing and ultrasounds, to making sure that she hasn't got any other issues in regard to getting the frequent urinary tract infections. I would ask her questions about her constipation and having a look to see what actually occurs. Is she getting diarrhea and then flowing on to constipation? What type of diet is she having? What trigger foods can help her? Which foods that are that can stimulate her to open her bowels that she can use to help her get a more reliable routine. We would look at some periods to see if they can help. This lady will need an examination to see the fact that she's had a hysterectomy in the past. We want to make sure that if she has any further prolapse that has occurred, that she has noted. I'd ask her also when the continence issues have started to occur. when yeah, I'll be looking at those. I think I'll hand that over to that's all I'll probably say for now. Thanks, Louise.
Thanks, Jemana. Anna, I might come to you, and I'm sorry, you had another point that you would like to make about Emma. My apologies, I missed that. Did you want to just add that now and then tell us about your approach to Diana as well?
Sure. So, just if I can remember the points, UGSA is the Urogynecological Society of Australasia. It's our national group, and they have patient information sheets. In relation to the young girl who's not had children, whose complaint is of stress incontinence, I agree with Janetta's investigation, workup to exclude neurological or other factors. I see young girls who often can't determine the difference between vaginal discharge and urinary incontinence. And so I think it needs that sort of assessment. I've seen a young girl who put a lava lamp top into the vagina and was too embarrassed to tell her mother. She was 14 and she went to see 2 GPs and eventually developed urinary incontinence, and it was this foreign body had created a fistula. So I think even and that would have been obvious just by inspection, not by examination, just by parting the labia. So I think, even one needs to keep an open mind about the potential causes. They can be very minor, like a vaginal discharge being confused, or they can be something much more serious, like a fistula. Susan Davis did a nice study that looked at young women, nulliparous women like university students, and found that 10% of women in that age group will complain of urinary incontinence. Now, this is usually not severe, it's relatively mild. The one thing that I found quite useful is a padway test. So that's a test that Jemana is very much involved with, and we get a young person to put on a liner or a pad that's pre-weighed. It's a way of assessing, getting a measurement of objective urine loss or objective fluid loss. And so that's one thing that we often use, as well as examination, before going to invasive testing, which we try and avoid in young women. With regard to this lady, the complaint that she has is that she has 6 UTIs. That needs investigation, needs workup. We need to do that by checking to see if there's what the organism is, have they been documented. About 25% of women who've had 1 urinary tract infection will get a relapse, a recurrent. However, 6 is, that's unusual. It requires investigation. It needs some imaging, either renal ultrasound or CT KUB. It needs possibly cytology. And once that workup, and potentially cystoscopy, once that workup for recurrent urinary tract infection has ruled out any underlying cause, then we can address prevention of further urinary tract infections. Topical estrogen is very important for prevention of recurrent urinary tract infections, and then cranberry, 36 grams, Hyprex, vitamin C. In terms of answering a question that came in, the best first line antibiotic for urinary tract infection, I think, is trimethoprim. But often obviously it depends on sensitivities, but if it's a convenient once a day dose, it doesn't have as much possibility for causing candidiasis as, say, Keflex does, but Keflex, Augmentin, Macrodantin. Obviously some women will not, will still experience recurrent urinary tract infections despite these prophylactic techniques, and so sometimes we need long-term or post-coital antibiotics, and if we're going to do that, once we've exhausted the other prophylactic measures, then we would do that on a rotating 3 month of one medication topic going on to another, because the biggest problem with that would be development of multi-drug resistance. There are a few other techniques that are used also, bladder installations, etc. And what's really exciting, and what will be discussed as part of the CFA meeting in Melbourne in November, is some new work that's being done at the Austin on a E. coli vaccine. So with regard to this lady, once you've investigated and sorted out the urinary tract infection, then that could be contributing completely to her urgency and urge incontinence issues, because that's a very potent cause of that symptom if there's any inflammation or infection. However, if she continues to have UTIs, rather OAB symptoms, urgency, frequency, then we would treat that in its own right with fluid optimization, anticholinergics, etc. And obviously the bowel care is important there. I think that's it for me. Thanks, Louise.
Okay, great. Janetta, what would you like to add to Diana's management?
Thanks, Louise. Yes, so just some things to add on there. Often women who present with recurrent UTIs will say, when you ask them about how they're voiding, they're straining to void because they've heard that, maybe the reason I have recurrent UTIs is that I'm not emptying my bladder properly. So then, they'll get into a straining pattern. So it's really important to avoid that, because, of course, that's not really helpful for the pelvic floor. If a woman is straining, significantly every time she voids, then she's at risk of developing pelvic organ prolapse, particularly being a para 3 and a woman who's had a TAH, a total abdominal hysterectomy. So I'm certainly interested in just checking her voiding technique, and also to make sure that she's not hovering over the toilet. Again, as hopefully everybody that's listening knows, you can't catch a UTI from a toilet seat, but you have to sometimes challenge women in their thinking on this, because that's what they've been doing and have been taught, as young children. I'm also really keen for Diana to not stop the flow of urine midstream. So again, she may have been taught when she had her children that that's a good way to exercise the pelvic floor, but in fact it's not. It can be used very occasionally, and ideally only once or not at all, as a test. So you'll still see in CFA pamphlets to check your pelvic floor muscles, you can stop the flow of urine and start again, but you should never do it any more than that once. And it's not really indicative of pelvic floor function, I don't think. So I don't actually ask women to do it. I'd certainly prefer that she's exercising her pelvic floor muscles at other times, because we do know that in a small proportion of women, by stopping and starting the flow of urine, then that actually can increase post-void residuals. Of course, with Diana, I'd like to assess her pelvic floor, as mentioned before, and the role of the pelvic floor there is to use pelvic floor contractions to inhibit detrusor activity. So for some women, long sustained contractions, so they may need to work on their pelvic floor endurance, may be helpful. For some women, on top of that, they need to use shorter pelvic floor engagement squeezes to help to inhibit the urgency, so that they can actually get to the toilet in time. And with Diana, I would consider the use of neuromodulation with TENS. So Anna's mentioned before sacral neuromodulation with implantable devices, but TENS machines can also be used for neuromodulation, so they're used externally. The idea being that there's an inhibition of the parasympathetic motor neurons to the bladder, and therefore a reduction in detrusor activity, also by stimulation to pudendal nerve afferents. So we're not exactly quite sure exactly how it affects the bladder, but that is the theory. Thanks, Louise.
Thanks, Janetta. I was just trying to find the question that came in that probably is for Anna relating to that case, and it was to do with older women and the use of the particular medication. Sorry, I'll try and hunt for it again, because it was probably relevant to that case study.
Yep.
And about the... Did you see that one, Anna?
Yeah, that was about, so the question was about Hyprex and vitamin C. I thought I included that in my list of prophylactic medications. The other thing that can be used is something that I don't have any personal experience with, but there's it's online available, D-mannose, so MANNOSE, 200 grams has been shown to reduce the risk of urinary tract infection. Hyprex and vitamin C, and vitamin C alone acidifies the urine. But Hyprex, in addition to that, there's some Cochrane data that suggests that it's useful for prevention of recurrent urinary tract infections.
I think it was another question I was looking at, but I'll try and track it down. It was to do with the anticholinergic medications being suitable in older ladies, I think. I'll try and find it so I can be more specific. Okay, let's move on to case study 3. We've got Dorothy. She's 74. She's got a few issues in her medical history. She's got incontinence. She's not clear what's causing it, and has a wet pad during the day. So we might just stay with you, Anna, while you're there.
Sure. Basically she needs a full assessment. She's not clear on what causes it, but maybe a bladder diary and an examination might give us an idea if she's got stress incontinence with coughing in the supine position or on standing. We need to assess her post-void residual. Definitely. She's got nocturia. The bladder diary is going to tell us what the cause of her nocturia is. If she's got sleep apnea, then she may have polyuric nocturia. In other words, her kidneys make more urine overnight than they make during the day, and she's fine during the day and she might void 3 or 4 times, but at night she makes 1.5 to 2 litres. And she needs to void overnight. So giving her anticholinergics is not going to help her nocturia. Treating her sleep apnea is going to help her nocturia. And then in terms of her incontinence, we need to address her mobility issues, like, she may have that as an issue in terms of osteoarthritis. And then in terms of the incontinence, then I think it's this person that probably, to make sense of, or to investigate her further, to fully assess her, we probably would go on and do a urodynamic assessment to see what's causing the problem. Thanks.
Okay. Jemana, would you like to add to the management of this lady?
Yeah, well, I would also talk to her about what pad she is using to help with her incontinence. Sometimes she may be using cloth pads. So talking to her about what's available now and what would actually meet her needs in regards to the amount of loss that she's having, so that things are more manageable for her. I've noticed that she's got some osteoarthritis in her knee. She may have some problems with mobility. Making sure that we have a look at, ask her about, can she access the toilet in a safe manner. She's getting up to the toilet quite often overnight, making sure that she's safe overnight. The last thing we want is for her to have a fall overnight. So just having a look at those things that can make sure that this lady is not at a risk of falls. There was a question that came up about what types of creams are suitable in regards to protecting skin. If this lady is having lots of wet episodes, she may have problems with skin. Some creams that have a zinc base can clog up continence pads, so making sure that you use barrier creams without zinc can really make sure that those pads are working to their optimum. Anna has already said that she would have a look at her urine to making sure that she hasn't got an infection. I'd also have a look at her diabetes and making sure that that's well controlled. If her diabetes isn't well controlled, can also contribute to some of the symptoms she's experiencing. Thanks, Louise.
Okay, great. And Janetta, would you like to add to the management of Dorothy?
Of things to what Anna and Jemana have already said. I'd like to talk to Dorothy about her general fitness. So both Anna and Jemana mentioned her mobility, so I may discuss with her ideas for maintaining her mobility and exercises that might be appropriate. So often women will say to me, you know, but I can't keep walking because my knees hurt so much. And so, you know, from a physiotherapy point of view, it may be appropriate to suggest shorter walks. You know, you don't have to go for a half an hour walk every day, just a shorter walk. Or it may be that referral to a musculoskeletal physio for assessment, perhaps hydrotherapy, some water-based exercises, you know, could be appropriate, but obviously we need to improve her continence first. And so therefore, you know, land exercises are going to be what she could do initially. But I know in Victoria, I'm not sure in other states, we have a program called Living Longer, Living Stronger, and they're fabulous exercise classes that are coordinated by the Council on the Ageing. You can just look what's in the area, in your area on their website, and I think that probably there would be similar things in other states. So, you know, there'd be quite a focus on her mobility as well as pelvic floor muscle training, because it's highly likely with all her comorbidities that her pelvic floor muscles are also quite weak. And, you know, as we talked about before, it's never too late to strengthen your pelvic floor muscles. And even if we can improve the hypertrophy of the pelvic floor and therefore improve urethral closure pressure, and even with endurance training of Dorothy's pelvic floor to inhibit the fatigue that would occur to her pelvic floor muscles as the day progresses, you know, that may be a contributing factor in reducing her incontinence. Thanks, Louise.
Okay, that's great. I think we've actually all contributed. Am I right? Everybody's contributed that last one. So that means we do have some time left for questions. So I think probably the best thing is to have a look at some of the questions that came in when people registered and see if there's any that we haven't addressed. So I'll start with this first one, which is what's the role that sonography plays in the initial diagnosis of incontinence and pelvic floor assessment, and what markers and measurements are you looking for? So I might give this one to you, Anna.
So ultrasound's used both by medical and physiotherapy and continence nurses. So generally, on a really basic level, the measurement of post-void residual is very key. And then in terms of incontinence, we use ultrasound to look at bladder neck descent. And it's fair to say that we add that to information that's gathered by the examination. There's obviously a lot of work that comes out of 3D translabial ultrasound out of Peter Dietz's unit, and many of us have sent our colleagues and our junior members to go and learn 3D translabial ultrasound with him, looking particularly at levator avulsion, at often it's very helpful when we're trying to diagnose something like a diverticulum, like a post-surgery, a sling, whether we think the sling's too tight. In terms of its role, I think it's fair to say that there is some research. It's a research tool, but there's also increasing clinical application as a clinical tool, I suppose, would be fair to say. I'll hand over to Janetta to let her explain how it has a role in physiotherapy practice.
Thanks, Anna. Yes, so certainly both continence and other musculoskeletal physios use either transabdominal or translabial, transperineal ultrasound to assess pelvic floor muscle function. And it's a great biofeedback tool. So, you know, if the patient, as with any biofeedback, if the patient is actually able to see her pelvic floor muscles working and making a movement, then that's certainly very motivating and will help her to improve the acquisition of the ideal technique. Also, a lot of musculoskeletal, general physios in the community may be using transabdominal ultrasound if they're not doing anything perineally or translabial. And it's very important to note there that what they're looking at is the work of the group of deep abdominal muscles, so particularly transversus abdominis, and also the elevation, hopefully, of the bladder neck rather than depression of the bladder neck. So using ultrasound transabdominally also can give very good feedback, but won't actually visualise the pelvic floor muscles. But it can be helpful in the situation where perhaps there's not access to a pelvic floor physiotherapist. But very important to note that it is bladder neck movement rather than the specific function of the pelvic floor. Also, do remember, those of you who are exercise physiologists, personal trainers, that just because a patient is able to engage her transversus abdominis doesn't necessarily mean that she is also engaging her pelvic floor. Thanks, Louise.
I might just follow up with you while you're there, Janetta. And someone's actually asked, and this is probably really relevant because in a lot of areas there may not be the expert pelvic floor physio, or there may not be a continence nurse, and they're unlikely to be a urogynecologist, especially in some of the regional and remote areas, as we know lots of our people tonight will be from. What is the difference between what a pelvic floor physio would offer and a continence nurse? And someone also asked, would a continence nurse be doing the same pelvic floor assessment of muscles, internal assessment of muscles that you might do? So 2 questions there, really.
Okay, thanks, Louise. Look, I think that, it's fabulous, as I have very fortunately with Jemana, to have great collaboration between continence nurses and physios, and that's been, since the inception of the Continence Foundation. I think in many ways there are things that we may discuss, as you've seen tonight when Jemana and I have talked about things that are very similar. So I guess, the main thing that a physiotherapist will be doing is educating her patients about pelvic floor muscle training, so assessing and really getting down to the nitty-gritty of, as I've said a few times, the acquisition of pelvic floor, correct pelvic floor function, and progression of programs to a functional level, and until there is either complete or maximal improvement in the patient's symptoms. As a part of that, then the physiotherapist may also be involved in bladder retraining, voiding techniques, certainly evacuation dynamics, other things that we've mentioned tonight. But the great thing is that there is lots of overlap, and quite often a patient will be seeing both continence nurse and continence physio, and of course then there can be a reinforcement and discussion between between the 2 health professionals. So it's really important, I think, to have that those open lines of communication. Also, Jemana and I were discussing earlier in the week that it's so helpful for continence nurses to be able to perform vaginal examinations because there are so many things that you can pick up and assist a woman with if you are doing a vaginal examination, as well as pelvic floor muscle function. You may not necessarily be progressing onto a pelvic floor training program, but certainly an assessment of even whether the woman is able to contract her pelvic floor correctly or not. However, if a vaginal examination isn't something that a continence nurse is trained to do, then even an external perineal visual assessment, in many instances you will either see that nothing's happening, see that there's some perineal, indrawing, or actually you may see, ballooning or a bearing down, and then there's ability to an ability to correct that technique. Jemana, do you have anything to add to that?
Sure that if you are a nurse who wants to do vaginal examinations, is that you get some education in regard to how to perform those examinations, as well as getting some supervision and making sure that you can perform those assessments. I know Nurses for Continence did run, they've run I think 2 pelvic floor examination courses that they've run. I think the last one was 18 months ago, and they were a fabulous way for nurses to become comfortable with assessing pelvic floor, looking for prolapse, being comfortable about making sure that they ask all the right questions. But you need to make sure that you've had that education. There's been a few questions about whether midwives are comfortable with teaching pelvic floor exercises, and I know on the CFA website they've got an extensive program for midwives specifically on teaching patients how to perform pelvic floor exercises. This will just be a talked about practice rather than actually hands-on. But as Janetta said, even just a visually looking on the outside, you can actually see whether someone is actually doing a pelvic floor contraction. Thanks, Janetta.
Okay, it's great. I think I've had calls to Jean Hales too about, you know, people, women's health nurses, for instance, who might work in a rural area where they don't have access to any continence health professionals at all, and they've asked, you know, what should be their approach or what can they do. So I think those courses that are available, that you can see at least through the Continence Foundation, are probably your best port of call. If you are a women's health nurse and you'd like to upskill in these areas, it's probably really worth having a look, because we know it's really difficult in the rural areas. I think we will now have to wrap up, because I know there are more questions, but if we start more questions, we're going to go over time, which I don't really want to do. But I would like to say a big thank you to our fantastic panel. I think it's been really great discussion tonight and lots of information. The webinar will be available if you want to come back to it. We'll send you a link later in the week so you can actually go back to it and have a look. You can actually download those resources. At the end, if you would like to, we would appreciate if you could fill in the evaluation. If you want to get points, if you're a GP and you want to get your points, complete the evaluation and you will be sent certification in the next few weeks. And a big thank you to our fantastic panel. I think it's been really, really great, informative discussion tonight. And a thanks to the Continence Foundation, who partnered with Jean Hales to present this event. And I think there probably will be more to come. You know, given the turnout tonight, we've had a really great number of registrations, and obviously we didn't cover some of the more complex things in terms of pelvic floor dysfunction, so that might be something we need to look at in the future for next year. But thanks for being part of tonight's webinar. We'll have more webinars coming up in 2016. This will be the last one that Jean Hales will be doing for this year, but we look forward to your feedback, and please give us ideas for topics you'd like to hear, and a big thank you to our panel. So thanks all very much, and thanks to the Continence Foundation of Australia. Thanks very much.